Now, PBC is a heterogeneous disease, and the risk of progression differs among different patients. So it's important to recognize what are the baseline factors in a patient with PBC that are associated with increased risk of progression, and what treatment endpoints should we be looking for in patients in whom we start ursodeoxycholic acid therapy as potential indicators for those individuals that may be candidates for treatment with obeticholic acid, or possibly other considerations of treatment, maybe refer for a clinical trial. So baseline and on-treatment alkaline phosphatase and bilirubin, baseline and on-treatment AST platelet ratio, and on-treatment biochemical response criteria have high confidence and wide applicability. There are some other baseline factors and on-treatment data that may have intermediate confidence and applicability, such as age at diagnosis, the disease-specific ANA that I mentioned earlier, and baseline and on-treatment transient elastography. There are others that may not be as useful in predicting prognosis or in delivering risk assessment, and these include histologic scores and possibly measurement of portal pressure. There are several established response criteria models that all essentially are permutations of trying to determine how a patient's laboratory tests, clinical findings may have improved after a period of ursodeoxycholic acid therapy. And the Barcelona, Paris 1, Rotterdam, and Toronto criteria all have used variable measures such as reduction in alkaline phosphatase from baseline, maintenance of a normal bilirubin, and maintaining an alkaline phosphatase below a certain level, in this case 1.67, after a period of ursodeoxycholic acid. The Rotterdam criteria are interesting in that they are a blended assessment of both risk and stage. This criteria uses albumin and bilirubin after 1 year of ursotherapy, and the best outcome was in patients who had a normal bilirubin and a normal albumin, and the worst outcome was in those who had an elevated bilirubin and a reduced albumin, with intermediate outcomes in patients with one of two criteria abnormal. Some recent modifications of the biochemical response criteria models, such as the Paris 2 and early biochemical response criteria model, and these all demonstrate that patients who are on ursodeoxycholic acid for 6 months to 1 year can be considered to be in a favorable prognostic criteria if they achieve alkaline phosphatase less than 1.5 times the upper limit of normal. More recently, we've developed some optimized response criteria models that are very useful clinically and are conveniently associated with online calculators where risk assessment can be calculated right in the clinic at the bedside. The biochemical response model, when added to the APRI, was useful. And the UK PBC score, and particularly the GLOBE PBC score, are prognostic indices that have developed on prospective, retrospective, or retrospective data collection using a variety of criteria and give you a risk assessment. And if the risk assessment is above a certain number, the patient is in a higher risk category, and below a certain number in a lower risk category. So this shows you the GLOBE score calculation. Obviously, it's a bit detailed, but it is a freely available calculator that you can bookmark and enter the patient's data and provide the results for survival estimates. The GLOBE score is a potent and useful score. As shown on this slide, transplant-free survival rates in patients with a high score were 42.5% versus 82% in patients with a low score. And 5 and 10-year survivals are also shown here. I find the GLOBE score very useful in my clinical practice, and since I have a practice that is almost entirely a referral practice, most of my patients have already been on ursodeoxycholic acid and are coming seeking second-line therapies such as obeticholic acid, or possibly enrollment in a clinical trial. And so using the GLOBE score helps us stratify risk very effectively. Here's an algorithm for how do you follow patients who are ursodeoxycholic acid non-responders at 12 months. So how do you define non-response? For us, it's an alkaline phosphatase greater than 1.67 times the upper limit of normal. Some people use an alkaline phosphatase greater than 1.5 times the upper limit of normal, and others an alkaline phosphatase greater than twice the upper limit of normal. But for a patient who has not responded or had a partial response, it is important to assess whether they may possibly be in that relatively small group of patients with true overlap syndrome, where the PBC component has been treated, but the autoimmune hepatitis component may need immunosuppressive therapy. Certainly, if the ALT-AST ratio is greater than 5 times the upper limit of normal, it would be prudent to consider a liver biopsy to determine whether there are features of autoimmune hepatitis. I would emphasize that, at least in my opinion, it is wise to perform a liver biopsy before initiating immunosuppressive therapy, which could be chronic and long-term, without knowing for sure that we're treating this condition. So a liver biopsy in this situation would be advisable. Now, if the patient is a man and has proven PBC and continues to have elevated liver enzymes, it's also important to consider that this patient would be a candidate for HCC surveillance, as liver cancer in men, particularly with cirrhosis, is significantly increased in terms of risk. And for patients who have PBC, who have persistently elevated liver enzymes or persistently elevated alkaline phosphatase, there is an appropriate consideration for either second-line therapy with obeticholic acid, which is now FDA approved and has been since mid last year, or consideration of clinical trials. Another way to stratify the patients who have been treated with ursodeoxycholic acid and have responded at 12 months is to evaluate the patient's APRI score and follow guidelines for HCC surveillance, depending on whether they're men or women, and depending on whether they have more advanced fibrosis or not. It's always important to review the fact that there is a contrarian point of view about the possible lack of efficacy of ursodeoxycholic acid. A Cochrane Review meta-analysis of 16 trials found no significant differences in effect between ursodeoxycholic acid and placebo or no interventions, and concluded that although ursodeoxycholic acid showed beneficial effects on liver biochemistry and even on histologic progression, all-cause mortality or liver transplantation was not significantly altered. The problem with these studies and meta-analyses is they tend to have a variety of different population of patients, and given that ursodeoxycholic acid is a long-term, slowly progressive disease, outcomes in clinical trials will be largely determined by the duration of follow-up and by the proportion of early versus late-stage patients that were enrolled in the study. For example, if you look at urso treatment failure, which is another criteria in which we evaluate patient status in trials, they may range from 10% for patients who present at older age and 60% who present younger age. And the likelihood of ursodeoxycholic acid treatment failure has been ranged to be as high as 39% or 60%, as I mentioned, and as low as 13%. And it is true that in addition to the severity of the disease at the time of diagnosis, age at diagnosis is an important predictor of long-term outcome. So for example, patients who are diagnosed at age greater than 70 are much less likely to progress, whereas patients who are diagnosed at age less than 40 are much more likely to have aggressive disease. So what can we do as clinicians for patients who have a suboptimal response to ursodeoxycholic acid? So that is those patients who have an alkaline phosphatase greater than 1.67 times the upper limit of normal after at least 6 months of urso therapy, or possibly as little as 3 months, and definitely after 1 year. It is important to question the patient for adherence. Specifically, to review the risks that patient may not be adherent because of side effects which they may or may not be attributing to ursodeoxycholic acid, such as weight gain, loose stools, hair loss. Confirm the dosage is 13 to 15 milligrams per kilogram, and recognize that increasing the dose of ursodeoxycholic acid above that has not shown benefit. It is important to avoid co-administration with a bile acid sequestrant because these patients would probably not be absorbing the ursodeoxycholic acid or any other medications that are given at the same time. And these are patients who are excellent candidates for consideration with obeticholic acid, which is now an approved second-line therapy for PBC.